to introduce ourselves so you get to meet. Half of the team is not here yet, but it's okay. We're going to get to meet the rest of the team as the day goes by. But we just wanted to welcome you to, this is our interdisciplinary team meeting, and it happens on Tuesday mornings. And we get together here, and usually it's an educational meeting, so we discuss different topics. And once a month, we do what we call a spiritual rounds. And the spiritual rounds is about care for the team, basically team care. So we talk about a patient, we talk about how patients makes us feel, how our personal life interferes with our palliative care practice. I mean, several things that we try. And we try to assign those to every discipline. So that's kind of how we do our team care once a month. Today what we're going to do is we're going to talk about the different services that we have here. I think you have heard this before. And after that we're going to go to the Clinical Skills Center where we're going to have an educational experience for you guys and the fellows as well. There are going to be also some learners like medical students and some residents that will be joining us. So I hope that you find this helpful. So we're just going to go around the room, introduce ourselves, and then we're going to get started.
Okay, I'm one of the fellows here, and I used to be in Temple with Mr. Care.
And Alicia, right? So
Alicia,
first name. Okay. Yeah, we go by first name. It's not Dr. or Miss or whatever here. It's just you. Okay, go ahead.
I'm Carla Sims, social worker and hospice palliative care coordinator at the Central Texas VA.
So that's Temple.
Temple.
Okay,
Yes.
good.
Joanne Cruz, nurse manager, hospice and palliative at Temple.
Robin Solon, staff chaplain, Dallas, VA.
Oh,
Long time.
Natalie's our camera woman. And Maricela, you know Maricela, we wouldn't be here without her.
Sarah Reimer, psychology resident.
Denise Minor Williams, nurse fellow.
Elizabeth Polanco, GEC physician, Dallas.
Jaime Diaz, palliative care fellow.
Phil Holcomb, volunteer in clinical ethics, I guess.
That's okay. Good.
Debbie Loya, social work palliative care fellow.
Okay. Me? And
Jenny Ross, Carly Angelo, social work palliative care fellow.
Yesterday and
Deborah Villarreal, physician, palliative care fellow.
And who's missing is our physician, Dr. Richards.
right. She went downstairs to get
Yeah.
coffee, and she told me she knew her way. Yeah,
Yes,
I
she
met her,
did.
so I was like, okay, you sure you want me to go with you? And okay. So we're just gonna get. So we're just gonna describe kind of the services that we provide, and I'm gonna make this as fast as possible and interrupt me at any time. The fellows know this by heart, so this is just for you, kind of to describe what we do here. This is our team. It's a little bit outdated. Some of these fellows had moved on already, but this is actually from last year. We're going to start with our palliative care unit. Dr. Beth Fidello is our medical director, and then we have Vicky Butler as nurse manager, and we're going to meet them tomorrow. This is the inpatient hospice palliative care unit, and the idea is that they provide comprehensive hospice and palliative care in an interdisciplinary way. The patients that we take are patients who are obviously terminally ill, or patients that require symptom management, or patients that require patients that are undergoing radiotherapy and chemotherapy mainly on a palliative way. So if they are receiving that treatment to help with the cancer, not necessarily to cure the cancer, we house them in our unit. And that's very common. For example, when we receive patients from the valley, like from Laredo or from Brownsville, of those patients that are about 5 hours away, obviously they are going to have to stay in a place, and they're not really that strong to stay in a hotel. So we house them here. And we use that unit for it. We do a lot of advanced care planning down there. We try to do it before they get admitted there, but sometimes it doesn't happen. Discharge planning is a big deal because many of those patients actually graduate from the unit, so actually they get to go home. And we try to do that and to help them as much as we can. So Bonnie spends some of her time there trying to help the patients transition from the palliative care unit to a home hospice setting. And then we actually have an educator to do, and we do a lot of patient and family education. We have about 20, we run from 20 to 24 beds at that unit. And there is a physician, a nurse practitioner, and nurses. And there's also a social worker entirely dedicated to that floor. Our social work fellow rotates through ECTC. Our chaplain fellow covers the patients. Our psychology fellow spends a lot of time there. And our physician fellows spend about 2 months in that unit. So as you can see, it's a huge deal. Interdisciplinary meetings happen on Wednesdays, so you're gonna go to the meeting tomorrow and you're gonna hear how, you're gonna hear different cases that they have. So this is what I just described. I'm sorry, I forgot to mention a clinical pharmacist. We do have a clinical pharmacist. We have different therapists. They work with the patients in different settings. They work in a subacute setting, and they also work to maintain range of motion. And trainees we mentioned also. This is our unit in Kerrville. You're going to be going there this afternoon. We have lots of beds in Kerrville, but there is a specific unit. Bonnie, do you remember how many beds do they have? Something on the range of 30 beds, but Dr. Martin will give you more accurate numbers today. And it provides comprehensive hospital palliative care. They also provide medical care, nursing care, and psychosocial care. Kerrville, so it's kind of the same unit that we have here, and it's the same model. We have a physician, we have a nurse practitioner, and we have social workers, and we have nurses, and we have a chaplain there as well. We rotate the trainees there, so at any given time our fellows spend 1 to 3 months there, depending on their different discipline and preceptorship. So we send them there. Who has spent time in Kerrville? You have, right? And Debbie will, and Jaime has, right? Okay. We do the same thing pretty much that we do here, as I said, but because they are on the northwest side of San Antonio, they cover that area. So all the area, I don't know if you're familiar with the hill country, but like Bandera, Medina County, that area is covered by Kerrville. The other people that we, for some reason, extended care beds here are very, very difficult to get. I mean, like, it's very difficult to get in because of so many patients we have. So if they don't have family in San Antonio, we tend to send them to Kerrville. So this is what I'm not sure about these numbers because it really varies according to the number of nurses that they have. But they do have more beds than we have, and they dedicate some of the beds to dementia units, and some beds to rehabilitation, and some beds to hospice. So Dr. Martin will give you better numbers today.
So there's not like a total hospice unit there?
There are beds dedicated to hospice, and Dr. Martin is the hospice doctor.
Okay.
So there is a unit. I'm not sure if I think they have it on a specific unit.
Okay.
Yeah.
Okay. So it's not branched out.
No.
Okay.
But the Kerrville, the main objective of Kerrville is to provide rehabilitation, dementia care, and they also have some long-term care beds. So hospice is not their main, although they do have a unit, it's not their main objective.
Okay.
And they don't do XRT or chemo patients?
They don't. XRT and chemo is done in San Antonio. Mm-hmm. So even if we had a patient from Kerrville that requires XRT or chemo, they're going to have to go here. You're going to see it's a little bit of a way. I mean, it's about 70 miles from here. So we couldn't be, driving back and forth every day. That would be really hard. Okay, so this is what we have there. Occasionally we have learners, as I said, not as constant as we have here, but we do send our learners there. The type of patients are different, and the team is also different. Now we're going to talk about the GEM clinic. So the GEM clinic stands for Geriatric Education and Management Clinic, and there are outpatient clinics that we have in Kerrville and in San Antonio. We managed over 1,000 patients in that clinic here in San Antonio. However, in our palliative care clinic, I want to say that the panel is about 100 patients. and that's what we carry at any given time. We have Dr. Ross is the one that runs the palliative care clinic for the fellows, and we have the 2 fellows have their clinic on Tuesday afternoon. So today, when you guys to the Kerrville, they're going to be doing their clinic. Our plan is to have all the fellows rotate through the clinic, and we're going to do that by the summer of this year. We have there's a social worker in the clinic that takes care of like advanced care planning and several issues, but we still use that social worker. So we're going to have to probably by the end of this year, we'll be able to get a good interdisciplinary clinic. That's kind of work still to be done, but we're getting there. So the patients that we see on the palliative care clinic are generally very sick and frail patients, usually older adults. They have, although it's a non-curable illness, it may or may not be terminal at the point. So patients with severe dementia, patients with cancer who are still getting some treatment, patients with severe liver disease, patients that have renal disease and do not wish dialysis, but they're not still at that point. Those type of patients, that's what we manage. They have many comorbidities, and many of them are on chronic opioids. So our fellows manage those patients, and they're very difficult. Right, Jaime?
Challenging.
Very challenging. Interesting.
There you go.
We occasionally receive consultations in the outpatient setting. So if other clinics need help with pain management or with symptom management, we provide those as well. So hospice care. Hospice care is done contracted outside. So if our patients have Medicare, we make sure that we refer them to a good hospice, and the hospice benefit is paid by Medicare. If the patients do not have Medicare or do not have any other insurance to pay for it, the VA immediately picks them up. It doesn't matter how many patients we have. At a given time, we have between 20 and 40 patients on contract. But as you know, those patients, they move on pretty fast, so we'll pick up new ones and so on.
So on contract, you mean VA pay?
Correct.
Which is $100 a day. About $25 less than Medicare. Okay.
The reason why they take contract patients in the hospice at that rate is because we provide a lot of their medications. We could provide a lot of their equipment. If they need to have cancer treatment, we don't deny that treatment, and they can still come to their visits with their physician, which we encourage. Some of those patients that are followed by hospice are actually followed by our fellows as well. So they come to the clinic, or they are also followed by home-based primary care, which is our visiting doctors program. And the other thing that is important to clarify here is that if a contracted patient require inpatient hospice, we bring them here. So we do that in extended care. Unless we have like no beds.
How long they can stay on hospice? Is it kind of like St. Christopher's, where you just manage symptoms and then get them out, or they can stay here until they pass away?
Are you talking about ECTC here? There's no limit.
Okay.
Many of them actually recover, not to completely be cured, but they do recover to be able to go home. But most of them, I would say most of them pass away here. And it takes a while. I mean, we have had people that have been here for 2 years.
Okay. Okay.
That's not the ideal, but that's... So we cover South Texas, and Bonnie is an expert in referring people all over the place. She has this map and this book that she carries around and starts looking at the little counties, the little towns. and then she, bargains with the hospices, and then you're going to be able to do this and that. So that's a big work. So that's what we do. We try to contract with the biggest hospices in town here. The reason is because they're gonna provide more services, and the other reason is because our fellows rotate through those hospices. So we, in some ways, ensure continuity of care. So that's kind of what we are. We like hospices that provide services such as massage therapists or alternate complementary medicine. Some of them do provide it. Some of them, for example, and we have had very cool things. For example, we had a patient about 3 months ago, still alive I think, that went home on a Milrinol drip, home hospice on a Milrinol drip. So we kept the drip, we provide the medicine, we were able to provide the pump, but the hospice administered the medicine. So that was pretty good. We have sent patients on TPN, very few of them, and it takes a great deal of coordination, but we have done that. We have had patients on different infusions. We have had patients that require weekly blood transfusions, and we do those here on home hospice. So that's pretty neat because we're able to get them at early stages, and we can control their symptoms before. That's very good. We like to refer to hospice patients early, so that's why we do all these educational activities, and we make sure that all the doctors and nurses know this, because we want those patients to be able to get the benefit of have a team at home, and they get familiar with that team at home, the same way that we would do it here.
When they come in through the emergency room,
Those are my favorites. No, those are Bonnie's favorites. No,
where do they get triaged to? Or?
Right. So it depends. So we had patients in which we actually could go. Our services are Monday through Friday, so we don't cover the weekends. If we have somebody with uncontrolled symptoms and they don't have any help at home, we admit them to the medicine floor, and from then we don't admit it directly to the inpatient hospice unit. Okay. Because it's very easy to get burned and to get patients who had other issues before we take care of them. So that's a problem. We really don't do that. But we could actually potentially do home hospice referrals from, and we have done it many times, from triage. So we go there, we evaluate the patient. If we think that the patient is able to go home, has good family support, and their symptoms are not too bad, then we are able to refer them right there, and hospice will pick them up from there. So it depends on the patient. That's the answer.
So when you have a private hospice, a patient come in, and they get admitted to the hospital, let's say a chronic obstructive pulmonary disease, MSI, they don't want to die at home.
Right.
When they get ready to be discharged from acute care, do you have to recontract with that particular home hospice?
Go to the next certification period.
They go to the next, okay.
Yeah. And that's pretty typical, not only in the VA but also outside, because they get admitted for something that is not related to the terminal diagnosis. Even if they were to get admitted, like we have the liver disease patients, the ones that require paracentesis every so often. So we admit them, and then they go to the next certification period, and we just recertify them.
Okay.
Yeah.
Now, the complementary therapies, do y'all offer those in the ECTC?
No, we don't, unfortunately. I do not have the resources to hire that right now. Unfortunately, that's a problem. But yeah, but I wish we had those, and hopefully we work on that in the future. These are the three main hospices we work with, and the reason is they are the biggest in town. They do have a lot of good coverage, good nurses, good inpatient unit in case we need an emergency, and they also take our interdisciplinary fellows on rotation. So our fellows learn the community stuff, and they take care of our patients as well, which works out pretty well. As you can see, veterans are not the easiest patients to take care of sometimes, and in the community, small hospices will get overwhelmed. So we refer to any hospice in town. If we had to take our pick, especially in difficult patients, we try to go with this ones. Now we're going to talk about the combined geriatrics and palliative consultation service, because that's something that you guys don't have there. And the idea is that this program provides medical care, nursing case management, interdisciplinary approach, and patient and family education. We encourage all our learners, all our doctors, and all our nurses to refer patients to the consult service. At this point, the consult service only works in the inpatient setting. And the outpatient setting has a much lighter screening, if you will, because that's mainly for placement. But first, I'll give you examples. So if we have patients who say somebody broke their hip, and they broke a hip and they really have no idea, they didn't want to go there to see what family they have, and they have no idea if they're in pain or not, and they have no idea what their functional status was before or what their mental status was before. At that point they call us. So we take care of all that, make sure that their mental status is taken care of, make sure that the pain is taken care of, make sure we speak with the family, that we have advanced directives, and then we kind of deal with, what's the best place for you to go. And it depends on many circumstances we help them. And we do lots of family meetings in the hospital. They call us to the most difficult family meetings. We just had one on Friday that we had to involve public affairs, patient advocates, the lawyer. We had to audio tape the meeting, and we had like 5 services involved, funny. Right. We had meetings with the police, presence of the police. We had meetings in which, social workers had gotten fired, It's very difficult meetings. So we deal with all the difficult discharges of the hospital. And that's kind of how they call us the most. But we are able to provide a lot of geriatric expertise and a lot of palliative care expertise because we advertise ourselves this way. So that's why we got that number of consults, which at this point I don't know what to do with. At this point we have 2 faculty physicians, likely to be 3 at the end of the year. We have one is our hospice coordinator and clinical nurse specialist. And we have another nurse who kind of works in the background. She forwards all the consults to the appropriate programs, and she takes care of all the numbers and the statistics because we have to report these numbers. Susan is our social worker, particularly for palliative care patients, and she also takes care of some geriatric patients who we identify have early palliative care issues, particularly advanced directives. And then we have all these learners. So at a given time, we have there's always a fellow in the consult service. Could be a palliative care fellow, or a geriatrics fellow, or a pain fellow, or an oncology fellow. And then there are residents. So at any given time. What?
But you have that on the next one.
Oh, I'm sorry. There you go. Yeah, I'm talking. All right, we have medical residents from internal medicine again. We are probably going to have to start family medicine residents rotating with us. We have medical students, and then we have the interdisciplinary fellows and others. In order to demonstrate the outcomes of the program, which the program has been in place for about 2.5 years, we had gotten a research grant. And Mary is, where's Mary?
She's in her office.
Oh, I'm sorry. Mary is our research coordinator, and she collects data from patients to evaluate their satisfaction with care, their quality of life, and so forth, to be able to report back. So we're going to be publishing articles, and hopefully this will help the VA and it will help you to justify another position. The reason why we're doing this is because most of the older adults, 40% of anybody admitted to the hospital and discharged from the hospital are older adults. And during this time, many of those patients do not receive care from specialists, and that's a problem. I don't know if you've seen this, but we've seen too many UTIs caused by follies. We've seen too many restraints. Delirium is a big deal here. Pain management is just a big deal. So this is what we do again. We perform a functional assessment of the geriatric patient. We provide interdisciplinary team care. We try to prevent, assess, and treat common problems of the elderly. We try to take care of special needs, particularly symptom management and advanced care planning, and we try to help them with complex coexisting problems, and this is particularly related to surgical units. This is kind of our algorithm. So these are the people who participate in the care of the patient. And we mainly get consulted to place patients to evaluate the best place for them to go. So in patients of acute rehabilitation, symptom management, and geriatric syndromes. So that's kind of what the overview of our service is. Now, I'm sorry it was so fast. Do you have any questions? Any questions, anybody? So we're going to be going to the Clinical Skills Center now.
You have, I thought I saw 24 beds here at ECTC?
Yeah, one, ECTC 1, yeah, correct. Okay. Which is hospital. For rehab, we have about 50 beds. Okay. So it's a total of 75 beds. Okay. And it depends on the number of nurses.
And in the hospice beds, you also get the more palliative symptom management or the
symptom management. Correct. Symptom management, terminal ill, and exertive treatment.
I do think I've got to go.
Yeah.